Welcome to the VHQC NHIN conference call. My name is Christine, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Linda Harris. You may begin.
Thank you, Christine. Good morning, everyone, and welcome to today's webinar, Fall Prevention in Long-Term Care Settings, a Culture and Partnership for Resident Safety. I'm Linda Harris, Improvement Consultant with VHQC. Other members of our team are Teresa Mandela, Improvement Consultant, and Sheila McLean, Program Director for VHQC. We ask that during our time together today, you are attentive and engaged, open and collaborative, and actionable. Today's session will be recorded, and you will be emailed instructions on how to access the audio recording from our online community. During the presentation, if you would like to share any thoughts or questions, please use the chat box, which is located to the right of the screen, and you can access chat by going to the top where the square that says chat and click on that. At the end of the presentation, we will open the phone lines for questions and answers. At the conclusion of the webinar, we will also post evaluation questions. Please take a moment before leaving the event to complete the evaluation because your feedback is important and appreciated. This slide is a listing of recent VHQC webinars that we have put on, and these webinars are available on the Nursing Home Improvement Network online community by accessing the link www.vhqc-qinqio.nint.com. Today we are very pleased to have Mary Files with us, and Mary is going to present on fall prevention. Welcome, Mary, and I will turn the webinar over to you.
Thank you. Well, I certainly appreciate the opportunity of being with everyone today. We have a lot of information to cover in about an hour, and I do want to preserve a few minutes at the end of the session for any questions that you might have. I have before you a list of objectives for today's discussion, and we're just going to go ahead and get started with these. I am not going to read every slide to you, but I've given you a lot of information for your benefit and future reference. So let's talk a little bit about the facts of falls in nursing homes, because it's certainly a lot more about the resident than it is just about our quality measures. And there are some astounding facts that I have found. The first is about 1,800 adults living in nursing homes die each year from a fall-related injury. When we look down a little bit further and we look at the average number of falls that occur in a nursing home, approximately a home with about 100 beds reports anywhere from 1 to 200 falls. Other information indicates to us that the average number of falls per person per year in a nursing home is approximately 2.6. And about 35% of those falls with injuries occur among residents who are unable to walk. So we've talked a little bit about how many falls occur. Of those, 10 to 20% of them result in serious injury, and approximately 2 to 6% actually result in fractures. Now, we know fractures are not the limiting part of this because there are many other associated declines, such as functional decline, reduced quality of life, simply the fear of falling again that can have a big impact upon a resident's quality of life throughout the facility. So what are the most common causes of nursing home falls? Well, obviously some of them are very obvious. Muscle weakness, difficulty walking, difficulty with gait. These are the most common things. But there are a lot of other things that we need to consider. One of these things are environmental hazards. Things that we do with the intent of creating a safe environment can also increase a resident's risk, and these often result in 16 to 27% of the falls among our residents. Use of medications that can increase the risk of falls and fall-related injuries. Drugs that affect central nervous systems, such as sedatives, and we've spent a lot of time over the recent years reducing the use of antipsychotics, and we'll extend that to now look at reducing anti-anxiety and hypnotics also. We'll also look at the way that we transfer residents, getting them from one locality to another, moving them from a bed to a chair, getting them on and off of the toilet or in and out of the shower, also increase their risk. One of the things that I think we do not do a good job is looking at making sure that our residents have appropriate foot care, that they're wearing appropriately fitting shoes, not just grippy socks, but shoes that can actually help them maintain their balance. And last but not least, let's not remember to look at, are they safe to use the walking assisted device that they have been given? When does that create a greater risk? Well, we've talked about some of the common causes, so let's actually talk a little bit about what this cost financially. In 2013, direct medical costs for falls of residents who had insurance and Medicare totaled about $34 billion. Now, a lot of that is directly related to the cost associated with hospitalization, and the average hospital cost for a fall injury is $35,000. And when we look at those that have fall injuries such as extensive fractures that then lead to other systemic breakdowns, that cost even gets higher. The older the resident, it tends to be the higher cost of caring for them in the hospital as a result of a fall because of the adverse complications that often occur. So let's talk about how we as a team can create a foundation for resident safety. The first opportunity that we have is to create a culture, to create a partnership and an environment of resident safety that involves everyone. It involves our residents, our family, and our staff. Making it all about the way that we do business, that everything we do, we have a check and balance to see, is that going to have any impact, a positive impact, potential negative impact. The second foundation is you can only create that and have it be successful if you know your residents, if you truly know their specific risk and their specific interventions that will promote safety. We can create a concept of safety within the environment, and that's important, and we're going to talk a lot about that this morning. But equally important is getting to know that resident, because that's what is going to make that environment a success for that particular resident. Now, we've talked a lot about making sure that we involve everybody, and involvement is the key word. Is that we're talking active engagement, creating a sense of partnership. And partnership means that we're all working on this together. So we want to look at strategies in which we can involve residents as part of their individual plan of care, residents with their input towards safety throughout the entire organization, family members, staff, contract staff, involve your consultants, and definitely involve your volunteers. So let's talk a little bit about what this involvement really means and how does it differ from each one of those categories of individuals that are going to be an active participant in this partnership. The first thing is getting the information out to them, letting them know we want your input. We value your thoughts. We value your planning, we value your feedback. So how do we entice? How do we educate? How do we let them know that we want them to be involved? The second one is increasing identification and awareness. Awareness of opportunities, identification of risk, awareness of our plan. How are we going to communicate that? Because it's going to be different according to each of the stakeholders that we have just talked about. And each one of those stakeholders are equally important. How are we going to solicit problem solving? How do we convey to them, I am really interested in your thoughts. I want you to tell me what you think. And how do we do this in a manner that it's going to be voluntarily given, honestly given, and quite frankly, honestly received? The way that we educate is going to be a little bit different for each one of these stakeholders. The methodology that we choose to educate for our staff is going to be different than the methodology that we use to educate residents. The methodology that we use to educate our residents is going to be very different than the methodology that we use to educate our residents. And likewise for volunteers or consultants. Not just the information, but the way in which we share it and the detail in which we share it. You've heard me use the word feedback. How are we going to get the feedback? How are we going to get it in a quantifiable manner? How are we going to get it in a manner that is positive for us to use? And we have to explore each one of these. And we have to ask each one of these stakeholders in a way that will include and encourage honest participation. So one of the things that I want to do this morning is spend some time talking about some common practices that we have throughout the nursing facility or the assisted living facility, and ask you to critique yourself and to think about whether or not these practices, although often put into place for a positive outcome, create a potential for adverse outcomes to your residents or create a potential of something that is not doable or able to be consistently carried out by your team. So the first thing that we often do, many facilities have resident identifiers. And these identifiers would say, this resident is at risk for falling. So first challenge that I have for you, what is your criteria for classifying somebody at high risk? How are high-risk residents identified? And that third challenge that I have for you is, does the number on your risk assessment drive your interventions? Now let me say that another way. Do I pay more attention because somebody is at high risk and put a preventive plan in place rather than recognizing the intrinsic risk factors of all residents and putting a specific plan in place that addresses the risk regardless of the rating or regardless of the score for that particular individual? But how do you classify somebody at high risk? And how do you identify so that other residents, so that staff, so that consultants, so that housekeepers, other departments know, hey, this resident has a higher probability. Let me just kind of be aware of what they are doing. The second bullet on this slide talks about the response to call bells. How do you measure whether or not your call bells are being answered timely? Now, many of you have sophisticated electronic systems that can generate reports. Sometimes those are good, sometimes they are flawed. But how do you know? And where are we teaching our staff to actually turn the call bell system off? We continue to have many facilities in which the call bell rings at the desk, and a person who is sitting at the desk or a specific location can answer that bell and say, Mrs. Jones, what can I help you with? And once Mrs. Jones replies, the light is cut off. 9 times out of 10, the person at the desk is going to say something, I will get your associate to come and help you. In the meantime, somebody has to go and locate that associate and tell them, and they often have to finish a task. So the delay in being responsive to Mrs. Jones's need is way beyond the time that it took somebody to answer that bell. So I challenge you, is your staff able to turn the call bell off at the desk, or do they actually have to go into the resident's room and visually see the resident and talk to the resident to see what is needed? That's not to say that every single time they can complete the task that the resident wants without going to get somebody else to help them. But oftentimes the call bells are for a request that does not require a clinical person to be the one to care for that resident. What is your system for evaluating timely call bell response by including interviews of the resident? There is no regulation about what the correct time is. The regulations talk about us needing to be responsive to the resident's need in a timely manner. And who to better judge whether or not we're being responsive in a timely manner than to get the information directly from the resident. The third bullet on this page looks at environment. We all want our rooms to look very nice. And 9 times out of 10, when I read a care plan, there is some intervention that talks about keeping the room free of clutter, keeping the hallways as free as possible. I want to challenge you on the ability and the flexibility within your organization to make room changes, to move the bed, to move the dresser, to lower a bar in a closet that would make the room more accessible and safer for the resident to move around in. I also want to spend just a minute talking about the use of signage. Very appropriately, we use safety signs when housekeepers are cleaning the floor. And everyone that I see is pretty religious about putting those signs up. Let me ask you to think about, do we pay the same amount of attention about taking those signs down and moving them out of the resident's way once housekeeping has finished? We also have spent many years thinking, I can't put a sign up in the resident's room. That's against HIPAA. That's a dignity issue. Well, it is when we utilize those signs that include private health information and when we utilize any type of sign that would embarrass the resident. But there are many residents who simply need a visual reminder. They need to be reminded that that door is the door to the toilet. Sometimes they need to be reminded to, here is your locker. Those types of signs can be appropriately utilized with the approval of the resident and the family, and they serve as good visual cues. So my challenge to you is go back and think about your internal use of signs. Have we moved so far to the right side that we have a philosophy of we can't have any signs? Or are we in the middle where we can actually think about the appropriate use of signage that would assist the resident who has the ability to respond to the sign and to keep them safer? Oh, and by the way, then the use of that sign would then become a care planning intervention. This particular slide is one of my favorites. This is a slide about purposeful rounding. Now, we all make rounds. And we say to our families and we say to our residents, somebody will be rounding. We round about every 2 hours, and that's important. It's whether or not we do purposeful rounding that will have an impact upon your success. And this impact that it has can reduce falls, can reduce behaviors, and quite frankly, can reduce the residents' use of the call bells when it is adopted as an interdisciplinary process. Now, purposeful rounding is, as I said, an interdisciplinary process. This is not just about nursing. So anyone that goes into this residence room is going to look for 4 different things. We call them the 4 Ps. And they're going to look for those 4 things within the scope of their own training and position. So, for example, the first P is pain. So if I am a nurse going in, no matter what I'm going in that room for, I'm going to observe and I'm going to ask the resident, are you having any pain or discomfort? And if the answer is yes, then I would proceed to see what I could do to make that resident more comfortable, whether it was the use of a non-pharmacological intervention or whether it was the use of a medication. Now, I happen to be a housekeeper, or I happen to be activities, or I happen to be social work, or any other department. That person can also still observe and can still ask the question. And we can tell when somebody is uncomfortable, oftentimes simply by looking at them and say, are you having pain? Are you uncomfortable? Now, the people that I just talked about, the departments that I just mentioned, are not necessarily going to be the ones that are going to medicate the resident. They cannot medicate the resident, but they can say, would you like for me to do something for you? Would you like for me to go get the nurse and have her evaluate your pain? So we're acknowledging the issue, but we are responding to it within the scope of our work. Same thing for positioning, okay? So I am now the social worker going in, and I see that the bed is cranked up so that the resident is sitting at 90 degrees. The foot is hanging over the side, okay? And the resident is got her head positioned so that it's down on her chest, and she's leaning to one side. It's a no-brainer. This resident needs to be repositioned. Now, as that particular discipline, I am not trained how to reposition that resident, but I do know how to call for assistance, and that's what I would do. I would call and have somebody else come in. So we've talked about pain. We've talked about positioning. Let's talk about the third P, and that's for potty. Do you need to go to the bathroom? Can I get somebody to help you go to the bathroom? Now, if I happen to be a CNA or I happen to be a nurse, I might say, do you need to go? But I might also be a little more assertive. And I might say, would you come with me? Let's go to the bathroom. So it's a matter of thinking every time we go in this room. The fourth P is personal belongings. Can I get something for you? Can you reach your call bell? Would you like for me to get you a tissue? Do you need your sweater? Anything that we could possibly do. So every person that goes in that room, many of us can always respond in some way. And if we cannot do what is needed for the resident, whether it be responding to pain, whether it be repositioning, whether it be assisting with some type of potty or toileting need, or whether it be handing them a personal item, we could always get somebody else. We're being responsive. And as we leave that room, we would check to say, is there anything else that I can do for you while I'm here? If everybody adopts that, and we make those rounds routinely in about the 2-hour increments that we've talked about, our residents are going to have less needs, they're going to have less potential for fall, and they are going to have less behaviors. So let's talk a little bit about environment from a different perspective. And let's talk about how the noise level in our facility can have an impact on resident safety. How often are you using overhead paging? And how does the use of overhead paging potentially increase or startle residents who have some level of dementia because they're not sure where it is or who is talking to them? How many safety alarms or other types of alarms do you have that are going off constantly in your building? Now, I want you to stop and think about something for just a minute. All of our life, we have been heard that when we hear an alarm, it means we get up and get due. We get up and get out of the way. It's an action for us. We hear a fire alarm. It means we get up and get out of danger. We hear a police alarm behind us in the car. It means we pull over and get out of the way. We hear the alarm go off on our stove because the cake is done. It means we get up and go take the cake out of the oven. Until we move into the nursing home. And the day that we move into the nursing home is also often associated with a decline in our cognitive ability. But all of a sudden, we expect our residents to remember that when they hear that alarm, it means to sit down. It's counterintuitive to everything that we have been taught our entire life. And many of our residents do not have the ability to discern whether or not the alarm they are hearing is meant for them or is it meant for somebody else. So an alarm that is applied to a resident for safety and appropriately applied for that resident can have a potential negative impact to another resident because that resident now can become startled and set them off balance or create a stimulation for a behavior that is going to increase their risk for falls or for injury. So we have to look at the use of alarms and noise throughout our entire facility. We also have to look at how one resident's behavior has a potential impact for creating a safety risk to others, not just for resident to resident, but simply because of the noise that is associated with it. I want you to think about how good a job do you do as a facility in terms of promoting exercise and mobility. And this can be done by a variety of different departments. How engaged is your skills therapy department? And let me be more specific. How engaged is your skills therapy department for those residents that would be utilizing Medicare Part B services, not your skilled services? How engaged and how active is your restorative nursing department? And is it a 24/7 program? Or is it Monday through Friday when somebody who is wearing a name tag that says they are restorative aid is in your building? How engaged is your activity department in terms of keeping residents moving? And I mean really moving. You know, not just playing a game of parachute, but on a regularly scheduled basis. And I would suggest daily, Monday through Friday, that there is some type of exercises that gets arms and hands and legs and feet actively moving, because the more that we keep those joints moving, the less problem that we are going to have. Let's look at the next slide and talk about facility schedules. We all live by a time clock. There's a time that most of our residents get up. There's a time that we serve breakfast. There's another time that a resident is particularly scheduled for showers. Toileting sometimes are individualized. Sometimes we do it based upon institutional times. And I want to talk about those three first. So I want to talk about them first for you to think about who sets that schedule, who does that schedule benefit. Does it benefit the staff, or does it really benefit the resident? How personalized is it? And I want you to think about whether or not somebody can change that schedule. Now, I want to come down and I want to look at the last bullet on this for just a moment, and it's called the turning and positioning. I want to offer you a challenge, and one of the things that I have learned over many years as being a nurse, we typically say that a resident has to be turned and repositioned every 2 hours, and we typically check them to see whether or not they need incontinence care every 2 hours. That was with all good intent. We certainly wanted to provide the appropriate care. We certainly wanted to reduce the potential for risk of pressure ulcers. However, new technology has come about, and we don't necessarily have to adhere to that 2-hour schedule anymore. And by looking and utilizing that technology, we actually can reduce risks to residents. So there are many new briefs that are designed to be specifically used at night. They have extra absorbency, and they not only have extra absorbency, but they also have extra wicking away so that that moisture is pulled away from the skin. Technologies in developing mattresses has changed drastically over the year, and many facilities are finding that it is a wise investment of their money to buy a better mattress, because the better that we are at reducing pressure, the better that we can minimize the risk of acquiring a pressure ulcer. When you put the use of a good quality pressure reduction mattress and the use of those high-quality incontinence products together, it oftentimes reduces the frequency in which we have to go and turn and reposition someone. Now, I want to stop for just a moment, because there have been many studies done that talk about when do the falls occur. And just anecdotally, when working with my clients, I hear, well, so many occurred on the night shift. And you know what, Mary? The aide had just been in there 15, 20, 30 minutes before, and the resident was fine. Well, that's true. The aide had been in to change them or to see if they needed changing, to turn and reposition them. Well, guys, we can't do that without interrupting their sleep. And when we interrupt that deep sleep cycle, it takes many of our residents a long period of time to get back into that cycle. In fact, it increases for a short period of time their restlessness. So yes, they were fine. They were sleeping. They didn't need to be changed when I was in the room. But I interrupted that sleep cycle, and now they have become restless. So now that's when they're going to fall out of the bed. That's when they're going to roll out of the bed. That's when they're going to attempt to get up and go to the bathroom. And they're in that state of half sleep, and that's where their biggest risks occur. So I want to challenge you to look at your turning and positioning and the use of appropriate products that can reduce it so that we can minimize the need to interrupt the resident's sleep as much as possible during the night. I want us to think just a minute about being proactive, monitoring for risk, involving your physicians, your pharmacists, and your therapists, looking at the use of diagnostic studies for osteoporosis, documentation of potential impact of disease processes, and the combination of medications on bone health and muscle weakness. Certainly, we're good at saying this medicine is going to create the potential for sedation or drowsiness, but we want to look at it beyond that. We also want to think about, are there opportunities for us to be more proactively treating these potential risks, the use of vitamins and supplements, the use of therapy to help them maintain good bone density, the use of protective devices to prevent injury, not just to prevent falls, and we'll talk a little bit about those as we go through. I want you to challenge your pharmacist. Help us review these meds. Don't just look for irregularities, but look for the timing and the combination of medications to see whether or not there is a potential for these meds to be impacting someone's risk for safety. Now, we all do risk assessments. I want you to think about the frequency of when you do these. We tend to do them on admission, readmission, quarterly, and with significant change. But are there other key populations or time frames within a subpopulation that they're going to see their biggest risk change? Let me give you an example. This would be a short-term resident coming into your building. They've had some recent anesthesia. There is an element of confusion. They're in an awful lot of pain, and at the point of admission, they are dependent upon their care. We bring them in. Their confusion begins to clear. They become a little bit more aware. They're able to make decisions. We give them therapy. They are now strengthened. They are now being more independent in mobility and or ambulation. Okay? And now, all of a sudden, they become the risk takers. So, did their numerical score change? It may not have changed. But did their reason for being at risk change? And oftentimes that tends to occur if they are responding positively to a good and aggressive rehab program between 2 and 3 weeks after admission. But yet, it's not quarterly, and we don't oftentimes go back and reevaluate whether or not their risks are different today than what they were when they were first admitted, and how am I going to respond to those risks? So looking at the timing in which you do these is critical. I also want you to think about your use of those risk assessments. Is it a piece of paper compliance or a form that you have to fill out on the computer because it's protocol? How good a job are we going and utilizing those risk assessments and then tying those specifically identified risks to something that is proactive and responsive in the resident's plan of care? The third bullet on this really talks about the fall assessment, not the risk assessment. The fall has now occurred. How good a job are you doing in drilling down to understand not the story about how the fall occurred, but the true story about why did this resident fall? Why did they lose their balance? Why did they slip on the floor? It's the why question that becomes critical for this. So I'm going to go through the next couple slides fairly quickly because there are common risk factors that we all know and we all address through our risk assessments or through completing our CAW assessments. The important thing is that we pay attention to each one of these risk factors and we really try to figure out how is Mary different from Sue and how is Sue different from John. We may have some of the commonality of the factors, but how it is important and how it plays out is going to be different for each resident. And that's where we end up with a successful program. Now I want to spend a few minutes time talking about some other risk factors and just being aware of them. So this first bullet talks about the use of medical devices. How many of our residents use oxygen? Quite a few of them. And the oxygen tubing itself can create a risk factor. It particularly creates a risk factor for residents who are ambulatory, and we can even extend that risk factor higher if they are ambulatory requiring the use of an assistive mobility device. So trying to maneuver from my bedroom into the bathroom using a walker and working around the 100-foot length of oxygen tubing can be a nightmare. The use of splints and other devices. Think about those orthotic devices that we wear to increase the stabilization of our ankle, for example, and oftentimes those devices themselves can create some significant imbalance in our gait. So making sure that we are looking at the impact of other positive things that we're doing to treat the resident's overall condition and understanding if they have a risk for resident safety. We want to look at activity preferences. Being safe to ambulate inside a building is one thing. Being safe to go and walk out in the courtyard and explore the outdoors on unlevel surfaces and on a ground that changes based upon the weather. So, for example, if they were going outside today, most of our lawns would be wet, slippery because of the rain, or if the grass was not wet, the lawn itself is spongy and creates a different standing balance or dynamic than if I were standing on a sidewalk. Or can they step off of a curb, or can they manage that little bit of a slope that we've put down so that we can safely get residents using other devices such as wheelchairs out of the building. So working with your therapy and your restorative to evaluate the resident's safety outside of the building is critical. This is absolutely my favorite slide. If you don't remember anything else that I said today, one size, one solution does not fit every single resident. You don't get more brownie points. You don't achieve a safer environment. You don't reduce residents' risk simply by putting every single intervention that you can possibly think about down on a plan of care. The key is finding the solution for that one resident and involving your other key stakeholders, including all direct care staff, in understanding why and what is important to that particular resident. So as you put your interventions and your care plan together, I want you to think about several things and measure the applicability and the potential for success. The first thing is the intervention responsive to an identified risk or cause of a fall? Secondly, is the intervention within current standard of care? Is the intervention acceptable to the resident or the family? Are they going to accept the recommendation? And fourth, Is the intervention consistently doable by the team? Is it realistic that the team is going to be able to carry it out on a 24/7 basis? So I want to spend just a few minutes talking about some common solutions. We've spent a little bit of time talking about safety alarms. For some residents, they're very appropriate, and we've also heard me say that for some residents, it can actually increase their risk. Some residents are able to use self-release devices to help them as reminders not to get up or to get out of a wheelchair. Other residents, it may actually serve as a restraint. Many of us think about our facilities as being restraint-free, and that's a good goal to work toward. But the regulations do not say that we cannot use restraints. It says we should not unnecessarily use restraints. So I want you to think about whether or not by being so strict in a philosophy of things we don't do, are we inadvertently increasing risk? Because sometimes the use of a restraint for a defined purpose and for a very short period of time serves as a means to help residents transition to a much safer environment. Fall mats. Fall mats can be useful for some residents. They are useful for the residents that tend to roll out of the bed. Fall mats, on the other hand, can increase risk for residents who attempt to set up on the side of the bed and stand because they now are putting their weight and their feet on a spongy type of surface. Fall mats can serve as an increased risk to other residents when they are not taken up during non-sleep or non-in-bed time because other residents now can come into the room. They attempt to roll over them to get to something that they want. Or the resident who is actually using the fall mat or supposed to be using it when they're in bed now rolls into the room and wants to get into the bed, and as such, they're struggling to get the wheelchair over the fall mat. So it has the potential for being a hazard to other residents. It also has a potential for being a hazard to your own staff and to visitors when they are not picked up when not in use. We've talked a little bit about the benefits of rehab and restorative. We spoke about activities in terms of increasing and helping the residents to stay mobile and actively engaged in exercise. But I want to speak just a minute about diversional activities because these can help redirect residents when they are having behaviors that place them at risk. But they need to be diversional activities that are responsive to a particular. What works for Mary is not going to work for Linda. We certainly want to evaluate ways in which we can address the resident's pain. And certainly as we look at creating a safe environment, we want to look and explore those non-pharmacological interventions so that we are addressing it not only on how to manage the pain, but we're also exploring how to minimize sedation. And oftentimes in doing this, we will see a reduction in behaviors. So again, I want you to think about, are the interventions of value to the resident? Is the resident responding to those interventions? Are they being used to prevent a fall, or are they being used to prevent an injury? For example, on many fall care plans, I see the interventions to apply hipsters. Resident is to wear hipsters at all times. Hipsters do nothing to prevent the resident from falling. Hipsters do something to prevent the resident from sustaining a major injury. So look and see for the interventions that you're using, are they creating a risk or are they being positive? Not only for the resident, but for other residents and staff. Involving those other key stakeholders are going to be important as you explore the effectiveness and the successfulness of those interventions. So, how do I prevent the falls? Well, the first thing is developing this sense and model of culture and resident safety and creating that partnership that involves residents and families and staff. Secondly, is really making sure that your staff know your residents. They know their fall risk and their fall history, and that they understand the interventions that are to be carried out to promote safety by both preventing the falls and preventing the injury. As our residents experience a change of condition, and not a change of condition that we are talking about having to do a significant change in DS, but as they begin to transition and have change of conditions, thinking about, does that change have any potential impact on the residents' safety and their risk for falling? Making sure that once that fall occurs, that we truly drill down and we not only get the story of how the resident fell, but we understand why the resident fell. And this is particularly challenging to us because so many of our residents are not able to tell us the why. They can tell us the how. Some of them can't tell us anything, and that means that we really have to become the investigators, and we have to not only assess that resident, but we've got to look at the room, and what does that environment tell us as a story? We have to interview other staff, other visitors, other residents, oftentimes to begin to get that story. So pretending that you are a CSI agent is critical in getting to the drill down, and one of the resources that I'm going to encourage you to use is the 5 whys, and that resource is available to you on the VHQC website. We prevent falls by tracking the falls, looking for the historical nature, looking for the trends and the patterns. And oftentimes we tend to focus on looking at when do the falls occur. Equally important is looking at those opportunities and those times when the falls and the risks do not occur, and seeing how we can begin to replicate those. So we've got some identifiers, factors that we want to suggest that you track. Certainly looking at time of the day, where the falls occurred, the activities involved, the folks involved, not just the resident, but the caregivers that were involved, were other residents involved, were family members involved. Was there anything of particular characteristic that would create a commonality that would give us more information so that we would be able to be proactive and minimize the recurrence? As an organization, you want to look at falls from 3 different levels at a minimum. You want to first look at them, what is the history and the pattern and the trending for the particular resident? Secondly, you want to look at individual units or neighborhoods or hallways, however your building is laid out. But what occurs on one unit is different than what occurs on another unit. And we often have units that are designed for specialty subpopulations that are going to have different factors. And then third but not least, what can we as an entire organization, and that's really the purpose of today, is looking at it as an entire organization to see what we could potentially do different. And when we find those variances, spending some time looking at those variances. And let me just encourage you that those variances are often impacted by the way that we carry out business. It's not always impacted by the residents. So when we have a unit that a large majority of staff have turned over, or we have something of that nature, that has an impact upon that entire unit. So start your investigations immediately. Interview everybody that you can possibly interview. Drill down to get to the real reason for the fall. Don't make early assumptions. Don't jump to a conclusion that you know why it occurred unless you actually saw it occur. So there are some CDC resources that we have made available to you. This first one is a booklet. It's a very extensive booklet presenting falls. It comes from the CDC. It's got step-by-step guidelines. I was a little bit surprised when I was doing the research of the information that came from the CDC, but this is a phenomenal resource, and I hope that you will take the time to download and look at it. The second one is also from the CDC, and this is a compendium of resources. It's got a tremendous amount of step-by-step instructions for both individual and small group exercises to keep residents moving. It has some common sense things in terms of home modifications, some additional clinical, and bringing it some interventions from across a very broad scope of multifaceted interventions. So two terrific resources that are available to you that I would encourage you to look at. The last slide is a food for thought slide, and then I'm going to turn it over to Linda because I know that we're just about out of our time. But I want you to think about three questions as you leave this program today. The first question is, what do you personally see as the risk in your organization for resident safety? The second question is, what do you see as a barrier or a challenge in your organization to creating a culture of resident safety and fall prevention? And then third, what do you see as an opportunity in your organization, a way to do something a little bit different, a way to get others involved with a focus on prevention? So I am going to see if I can't turn this over to Linda and let her take the screen.
Okay, thank you, Mary. That was a wonderful presentation with a ton of great information and a lot of ideas for us to think about as we develop a fall prevention program. Excuse me. Randy, I'm going to ask you at this time to post the evaluation since we are right at the top of the hour. So if you would please post that, and I would encourage you to please fill out the evaluation. We do use this information that you give us to plan for future webinars. So tell us what you like, tell us what you didn't like, or if you have ideas about future webinars, information you would like to receive from us, or topics, please let us know, and we will consider that in looking at our future webinars. I think probably we are out of time and won't take any questions, but I do encourage you to, if you have a question and you'd like to submit it into chat, I will gather those and get those to Mary, and we will get answers and send them back to you. Also, if you would like, you can submit a question to me. You can just email me directly, and that's lharris@vhqc.org. And again, if you have a question and you want to submit that to me, I will get it to Mary, and we will get you an answer. The tools and resources that Mary mentioned from the CDC, if you go to our online community, we have a link, we have a direct link to those resources. It'll be an easy way for you to connect. And please feel free to visit the online community or the tools and resources that we have to offer. At this time, I would like to thank everyone who has participated today, and I offer a special thank you to Mary for her insights on fall prevention. So if you would please take a moment to complete the evaluation before you leave. And with that, I'd like to again thank everyone, and I hope that you have a great rest of your day. Thank you.
Thank you, and thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect. And you're in your private post conference.
Okay, thank you.